Hello and welcome to my channel. This lecture we're going to continue our discussion about the liver, so let's begin. The microscopic structure of the liver shows a hexagonal network of connective tissue that has the hepatocytes in it with the branches of the triad, the common bile duct, and the hepatic artery, the portal vein, and in the center is a tributary of the hepatic vein. As you can see here, see the hexagonal structures. At the corners are the triad, a branch from the bile duct, the portal vein, the hepatic artery, and at the center there is a tributary of the hepatic vein, as you can see it here in this illustration. So the blood goes from the portal vein, mainly that's for the function of the liver, through the sinusoids, gets filtered and processed, and then into the hepatic vein to the general circulation. This is how the liver works. But this is called the anatomical lobule of the liver. So it's a structural lobule. We have a physiologic lobule in which you take into consideration the direction of blood flow. So a triangle with the triad in the middle, where the hepatic artery or the portal vein pouring its blood in all directions, as you can see here, and picked up by the surrounding hepatic veins. This triangle is called the physiological lobule that reflects the function of the physiology of the liver. Now there's another lobule or acinus called the pathologic acinus or hepatic acinus, in which at the corners there are two tributaries of hepatic veins, and in the middle the blood flows to their direction from either the portal vein or the hepatic artery. Why is this called the pathological? Because this is the way the liver tissue gets, its disease, its sickness. Even the zone, the pathologic acinus is differentiated into zones. The first zone, which takes the maximum hit, and then the second zone and third zone, and so on. So this is the spread of disease in the liver takes place according to this pathologic acinus. So now you can differentiate between the anatomic lobule, the physiologic lobule, and the pathologic acinus of the liver. Three ways to describe the structure of the liver. The blood supply of the liver, there is blood for the survival of the liver, which comes through the hepatic artery. The hepatic artery is a branch of the common hepatic artery. As you can see here, the common hepatic comes from the celiac trunk, gives the hepatic artery proper after giving the gastroduodenal artery. The hepatic artery ascends and divides in a V-shaped manner near the porta hepatis, and subdivides inside the liver till it reaches the final distribution in the anatomical lobule of the liver. The right hepatic artery, or the left, or the common, or the hepatic proper, gives off the cystic artery that supplies the gallbladder. So it differs its origin, the cystic artery, either most commonly from the right hepatic, the nearest artery, or comes from the left branch or the hepatic. But either way, it passes through the branch. They found out that it passes through a triangle bounded by superiorly by the liver and by the hepatic ducts. This is called the callus triangle, in which in surgery they go to this area to find the cystic artery in order to devascularize the gallbladder before excising the gallbladder. So this is called the callus triangle, bounded by the hepatic ducts and the liver, through which whatever the source of the cystic artery, it will pass through this triangle. Now, for the function of the liver, blood comes through the portal vein, and of course by now you know that the portal vein ascends in the free border of the lesser omentum after being formed by the union of the splenic vein and the superior mesenteric vein, and eventually the portal vein tributaries cover all the GIT. Any blood coming from the GI must pass through the liver through the portal vein. And it's worthy of noting here that at this area, see the direction of blood in portal vein and the direction of blood of the hepatic proper, both blood directions at the same direction, parallel to each other. We discussed this in another area, remember, in the thorax, where the coronary sinus and the left coronary artery or the circumflex artery blood was passing in the same direction. So this is another area where you can find blood passing in a vein and an artery in the same direction. Now, the venous drainage of the liver through hepatic veins. The hepatic veins form two groups, superior group and inferior group. Inferior group, multiple tributaries from the right lobe of liver, right lobe of liver and the caudate. This is called the inferior group of hepatic veins. The superior group of hepatic veins are three veins, right, left, and middle, and they all open into the inferior vena cava before it leaves the abdomen and enters the thorax through the vena cava opening in the diaphragm. So actually the last tributary of the inferior vena cava, you can consider it as the hepatic veins. Hepatic veins have no extra hepatic course. They are all intrahepatic, and they run in canals, the walls of which are by connective tissue, so they are always kept open to make sure that the blood flows fastest as it can. And there are no valves in these veins, as you can see here in a cut section of the liver. See, these big gaps are the canals for the hepatic veins. So the hepatic veins, they occupy these canals, which are guarded, or the walls made by connective tissue. So this is the blood supply. Remember, there is a blood supply for the survival, blood supply for the function. For the survival, we discussed the hepatic artery, how it subdivides in the liver and responsible for the liver segmentation. Actually, the segmentation, you can go by the subdivisions of the hepatic artery or the bile duct or the portal vein, because they all run in the same bundle, not the hepatic veins. Please remember this again. Okay, the lymphatics of the liver along the esophagus and inferior vena cava to the parasternal lymph nodes, along the diaphragm. Remember, there's a bed area related directly to the diaphragm, so lymphatics pass through the openings in the diaphragm to inside the thorax, to the diaphragmatic and parasternal lymph nodes, and this is how the hepatoma metastasis spreads or involves the thorax. The rest of the hepatic and celiac, rest of the liver to the hepatic and celiac lymph nodes. Hepatic lymph nodes at the porta hepatis, and celiac lymph nodes around the celiac trunk. The gallbladder to the hepatic nodes, but there's also a cystic node and a single node at the free border of the lesser omentum, called the node of the anterior border of epiploic foramen, or the foramen of Winslow, but eventually all will drain into the celiac lymph nodes, and from it to the cisterna chyli and thoracic duct. So this is the lymphatic drainage of the liver. The innervation of the liver, of course, it's autonomic because it's an organ, viscera. There's hepatic plexus. Remember this, that formed by the hepatic branches of the vagal trunks that we discussed, we studied with the stomach. Remember the vagal trunks, anterior and posterior vagal trunks. Give hepatic branch that forms the hepatic plexus that has a sympathetic component responsible to supply the vessels and for conveying the pain sensations, and the parasympathetic supply that's responsible for the contraction of the gallbladder and the bile duct to empty their contents in the intestine, which is bile, for the digestion and absorption of fats. So this is how the liver gets its nerve supply. Now for the biliary system and the gallbladder. Of course, the biliary system starts with the bile canaliculi inside the liver from the triad corners of the hepatic lobule. They all coalesce and assemble to form the right and left hepatic ducts. As you can see here, this is, by the way, an ERCP, endoscopic retrograde cholangiopancreatography. This is the endoscope injecting a dye through the ampulla of Vater that filled the pancreatic duct, as you can see here, and the common hepatic duct, as you can see here. And the way the dye spreads, they can diagnose if there is a stone in the cystic duct or the hepatic duct, whatever the stone may be. So as you can see here, these are the bile canaliculi assembling to form the right and left hepatic ducts, as you can see here. They form the hepatic duct that joins in an acute angle the cystic duct. See the cystic duct? This is the gallbladder, and this is the cystic duct. Joins the hepatic duct as at an acute angle to form the common hepatic duct, which opens in the posteromedial surface of the second part of the duodenum at the major papillae, and the opening is guarded by the sphincter of Oddi. The sphincter of Oddi that regulates the flow of bile from the biliary system to the small intestine. Now for the gallbladder, it's a sac, that stores bile, not only to store it but to concentrate it. This means it absorbs water from the bile to concentrate it until usage after meals. And see the gallbladder bladder. It has a fundus, has a body and a neck. The fundus of the gallbladder is present at the junction, at the tip of the ninth costal cartilage, approximately at the junction of the midclavicular line and the transpyloric line, as we studied before. And so it projects beyond the liver, the inferior border of the liver, and touches the anterior abdominal wall, and behind it is the transverse colon. Now, the importance that it touches the anterior abdominal wall, we can use this as when we examine the liver, if we're suspecting cholecystitis, any pathology in the gallbladder, by means of detecting the Murphy's sign, in which when you deep palpate for the below the liver and ask the patient to take a deep breath, he holds his breath once the fundus of the gallbladder touches your hand, and this is called the Murphy's sign. Now, we talked about the Boas sign, which is the pain from the gallbladder that's referred to the back of the shoulder in the case of cholecystitis. Okay, the body of the gallbladder, continuation of the fundus, projects into the neck. Now, the body and the neck are related not to the colon, but to the duodenum. Remember that, in the relations of the duodenum, and of course to the liver anteriorly, because they all lie in the fossa for the gallbladder. This means that if something wrong in the wall of the gallbladder, involves the wall of the gallbladder, adhesions will be formed and the erosion of the gallbladder will occur. If the erosion occurred at the fundus, it will involve the wall of the colon as well. So the patient will get bile in stools, that's dark stools. But if the erosion occurred in the body or the neck, it will involve the small intestine. See this small distance between the fundus and body and neck give totally different signs. If it's in the fundus, which is related to the transverse colon, so the patient will get dark stools. If the erosion in the body or the neck, the patient will get bile-stained vomitus. See, from the upper GI and lower GI, only by this minute difference in distance between the fundus and the rest of the gallbladder, the body and the neck. Of course, the body and the neck related to the quadrate, neck related to the quadrate lobe, and the body to the second part of the duodenum, and the liver as it descends, as it ascends actually behind the liver in its fossa. The cystic duct, you can see here the cystic duct coming from the gallbladder. These convolutions inside, the mucosa takes a spiral manner. Why? To slow down the flow of bile in the duct, and this gives more chance to concentrate the bile. See, first of all, it gives more chance to concentrate the bile, absorb water from bile, and it's a kind of valve-like action to control the flow from the gallbladder to the duct. Of course, a stone in the duct or in the gallbladder will occur right after meals because the gallbladder contracts due to parasympathetic stimulation after meals, and the stone will lodge inside the duct and cause the pain we call biliary colic. This is the typical biliary colic, which starts right after meals. Okay, so this is the biliary system. The blood supply, the common bile duct, upper part takes part from the cystic artery, the middle part from the hepatic artery, and the lower part takes from the superior pancreaticoduodenal artery branch of the gastroduodenal, remember? So it takes from three different sources. The gallbladder itself take from the cystic artery, which we talked about, that comes from the hepatic artery proper, or the right or left branches. Okay, now one thing worthy of mentioning here, that metastasis coming through the superior mesenteric vein go to right lobe of liver. Actually, the blood streams from the superior mesenteric vein and the splenic vein, because they are different in content, so they rather run in their own stream in the portal vein. They get mixed, yes, but not right away. They get mixed, so they run in two streams in the portal vein, with the one from the splenic and the one from the superior mesenteric. The one from the superior mesenteric finds itself going to the right branch of the portal vein and going to the right lobe of liver. So metastasis coming through the superior mesenteric vein, most probably you will find it in the right lobe of liver. We talked about the gallstones and the pain and the Bowes sign and Murphy's sign in cholecystitis. Now, to summarize, the blood supply of the GIT, the foregut that starts from the esophagus down till the middle of the second part of the duodenum, by the celiac trunk, by branches of the celiac trunk, as we studied before. Now, from the middle of the second part of the duodenum down, through the duodenum, jejunum, ileum, cecum, ascending colon, and the right 2/3 of the transverse colon, all take from the superior mesenteric artery, as we studied before, the blood supply of the colon and small intestine, from the junction of the right 2/3 and left 1/3 of the transverse colon, left colic fracture, descending colon, sigmoid colon down till the rectum. This is the hindgut. The artery of the hindgut is the inferior mesenteric artery coming out of the arising from the abdominal aorta, behind the third part of the duodenum, as you recall, and giving the upper and lower left colic branches, as we discussed before, with the blood supply of the colon. So this summarized the blood supply of the GIT, and for you not to get confused, if you forgot the blood supply of a part of the GI, remember these facts and you will be able to detect the branch that you're asked about. So this concludes the lecture about the liver. Next time we will be studying the urinary organs. I hope you got the maximum benefit from this lecture, and thank you very much for watching.